Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban. Welcome to episode 288 of the podcast. It's September 13th, 2017. We've got a little bit shorter episode than usual. This is part of the conversation that I recorded with Dr. Dean Gruner. He's the recently retired CEO of ThedaCare. We talked, what you're going to hear in this episode is our discussion about accountable care organizations, other big healthcare reform topics. We recorded that first, and then we got into talking about what you actually heard in episode 286, talking about ThedaCare's lean journey and some of his reflections there. So I wanted to get that story out first, his reflections, and then this shorter 15 minutes or so on healthcare reform. So I hope you enjoy this episode. If you want to hear the other one, you can go to leanblog.org/286, or you can find this podcast in iTunes, other directories. You can find the episode. I hope you will subscribe, and I hope you enjoy the episode. If you want to find the link to this episode, I should point out, you can go to leanblog.org/288. Dean, welcome back to the podcast. How are you today?
I'm great, and I'm looking forward to this.
And first off, I should say, well, I'm happy to hear you're doing great. Happy retirement to you, by the way. How long has that been now?
About 6 weeks, but who's keeping track?
Well, and I'm sure there were, if I'd asked that same question back when you were working, I probably would have gotten the same response. And I'm happy that we have the chance to hear some of your reflections on your tenure as CEO at ThedaCare, your career and lessons learned. So thank you again for being willing to do that today.
You bet. Happy to share.
So, there might be a few listeners here who have listened to, every single podcast going back. And I want to follow up on, we've had a couple of conversations in the past, in particular episode 144 from, about 5 years ago. For anyone who hasn't listened to that, you can find that at leanblog.org/144. And Dean, you talked to us about ACOs, accountable care organizations. And, you said at the time you were doing an experiment, 20% of the health system revenue. And I'm curious, what your thoughts are on how that experiment played out over time. What are some of your reflections on that?
We learned a number of things. So the 20% experiment was really with the Pioneer program. We did with Bellin Health in Green Bay as a joint venture, so to speak. We did that from 2012, 2014. We learned a lot. We were cited by Medicare in 13 and 14 as their highest quality, lowest cost ACO in the country. So we were very proud of that. Mm-hmm. And then we set out 2015 for a transition year, and we have continued now with Next Gen in 16 and 17. So between that, those pilots and our own employees, it's been about 23% of our revenue stream in total cost of care risk.
And what kind of organization is NextGen? Or can you maybe give a bit of background of how that ACO partnership works and what that meant for you and them?
So NextGen is the next generation of CMMI's total cost of care risk platform. So the Pioneer has migrated to NextGen. We have an ACO with physicians and ourselves. One of the things we've learned, though, is over the last 5-6 years, we had numerous conversations periodically with some of the large insurance companies, and they told us that they were piloting different forms of total cost of care risk with providers around the country, and that as soon as they were ready, they would be willing to talk to us and expand that to our platform. In fact, that's never happened. So we're disappointed with that, and I'd say a little disillusioned with that too, in that we think that the large for-profit insurance companies really do not have a sincere interest in in sharing total cost of care risk with provider systems.
So, so for my imperfect understanding of all this, so NextGen was an evolution of the Pioneer framework, and you said you originally partnered with Bellin Health, which was more of a primary care clinic organization. Is that right?
No, they're an integrated delivery system like we are. They have two hospitals and employ physicians and have a lot of independent physician partners as well. Yep.
Okay. And so that partnership, that ACO with them ended though, correct?
That did. We transitioned it to each forming our own ACOs.
Okay.
But we still work together closely. In fact, we will anticipate in the next 1 to 2 months announcing a new joint venture with a separate insurance company that we think has very high potential to deal with the triple aim issues that most of us aspire to achieve.
And can you elaborate a little bit? I mean, when you say insurers, commercial insurers, generally don't have interest in these shared models. What do you think is the cause of that, or some of their thinking on that?
I'll give you a little bit of my background and then tell you what I think in sort of an unvarnished truth. In my perspective, it may not be truth, but I started off as a family practice physician. 4 years into practice, I was the lead physician when we formed our own HMO, our own provider-sponsored health plan. We had 17 years, and we sold that health plan. That was 13 years ago. What I believe to be the case is that large for-profit insurance companies are in business to make money for their shareholders. And although they talk a good game about how they're doing things to hold down costs, the fact of the matter is they make a certain percent margin on average off premium dollar. As the premium dollar goes up 6, 10, 14% a year, they make that percentage of a larger and larger revenue base. So they will deny this until the cow comes home. But I definitely believe that they really are not as altruistic as they would claim to be, and that the reason they put in different mechanisms to reduce cost is so they can make more money. In fact, if they were to shift that total cost of care risk to providers, then when providers redesign healthcare using lean and other strategies and improve the quality of care and reduce the cost, the provider systems would benefit financially from doing that work. Today, when we do great work and redesign things, the beneficiary of that is the insurance company. They get the profit from our labor. And they don't really want to change that because it's working well for them.
Yeah.
So why would they change that? I mean, I can't explain why else. After 5 to 7 years of conversations with insurance companies, why none of them have been able to follow through on what they claimed they were going to do in 2010, 11, and 12, right after the Affordable Care Act was passed.
Yeah, and one element of the Affordable Care Act, which I've already demonstrated through my questions, I'm not an ACO expert, I'm not an ACA expert, but there's the one aspect of the law, the medical loss ratio, or it's sometimes called the 85-15 rule, if I have this right, where the insurers have to spend 85% of premiums on care, and it seems like, boy, if I were running a business, a larger pie benefits the insurer. And it seems like a disincentive to helping keep spending down, right?
So what people don't talk about is what happens to that 15%. And most large national insurance companies are proud of the fact that their admin costs, their administrative overhead, probably is between 6 and 8%. So their profit margin then probably is 7 to 9%. Now, it can be, covered up by all sorts of clever things that CFOs do. And you can call some of it R&D expense and this and that and the other thing. but it's a significant profit margin on average. And, as the revenue enlarges, that 15% becomes a bigger and bigger number. So I really don't think they have, it doesn't benefit them if they were to have healthcare costs stay flat year after year after year. Mm-hmm. They don't win. And if it's a capitalistic structure that we're in, I guess you can say you don't blame them, because they're there to make a profit for their shareholders.
Yeah, and
they're not there to, so yeah. But that sounds pretty jaded, I suppose. But it's not intended to be jaded. Yeah. It's just intended to, let's take away the magic screen behind the Wizard of Oz, and let's just call it what it is.
Yeah. Well, and what you say makes sense. And I put my MBA hat on, and figure a lot of times things are explained by systemic structures. I've seen some analysis recently that talked about not just insurance companies, but pharmacy benefit manager programs, and a lot of these structures that just have real disincentive to keep costs down. Even though the pharmacy benefit managers would claim to somebody, we're helping you manage and keep those costs under control, but they seem to systemically make more profit off of higher pharmacy costs.
Now, if you want to talk about that, in about 2000, we brought our pharmacy benefit manager in-house to our health plan, and then we subsequently created a separate company from that PBM experience. And that company is very successful, but we learned the dark secrets of the PBM business when we did that. Mm-hmm. They told us that it was incredibly risky to bring it in-house, and it was risky, and it was very difficult. And oh my goodness, how challenging that was. But what we found was that the PBM we had used previously had consistently given us about $1 per member per month of rebate. And they would get that about 9 months delayed. And we brought that in-house within 1 year. We were getting more than $5 per member month rebate, and we got it within 90 days. So we were absolutely believers that they used that rebate to make a huge profit margin off of our work, And
so, that was in relation to ThedaCare, the health system, not ThedaCare, the employer, right?
That was related to Touchpoint Health Plan, which was owned 50-50 by ThedaCare and physicians. Okay. So, yeah. So I was the chief medical officer helping lead that organization, and that was one of the things that I worked on with other people to do. And so we rolled back the curtain behind the Wizard of Oz in the PBM industry, and there are better ways to do it. Yep.
Now, do you think what you experienced is fairly representative of broader trends? I mean, if the Affordable Care Act and who knows, by the time I have this podcast published, who knows any of this, but let's say the Affordable Care Act remains the law of the land. Are there reforms or changes that would be helpful in this regard in terms of some of these incentives regarding ACOs, the medical loss ratios, pharmacy benefit margins?
Well, the way I try to explain this, Mark, is using sort of some of the principles of what we learn within Lean. So if you do something and you do an improvement event, you're usually very happy using the 80-20 rule. If you got 80% of it right, and I think that's what it is with the ACA, if you got 80% of it right, roughly. So what do you do with the 20% that's not working so well? Well, you do a plan, do, study, adjust cycle. You study it and adjust it. So the logical thing to do with the Affordable Care Act is to keep the 80% that's working pretty well and identify the 20% that's not. And part of it is, the exchanges are at risk in many communities. Well, they're at risk because what was feared by insurers has happened, which is young, healthy people have chosen to not buy health insurance and instead pay the penalty. Well, if the principle of insurance is that the healthy people help offset the sick people, just like car insurance. You know, of a car, someday you're going to be in a car accident, most likely. But you know that the 9 years you're not in a car accident, your premiums are going to pay for somebody who had a car accident. And the reverse is true the year that you might have one. So the same principle applies to healthcare, except if you have a lot of the healthy people opt out, then there are real losses for insurance companies.
Right.
So a lot of the insurance companies are dropping out of the exchanges because the way the law is written, it doesn't force the healthy people into the marketplace so that their premiums can be used to offset the people that are unlucky and unhealthy in any one year.
Right. And it seems like the penalties, even though they have increased over time, are still apparently low enough to be bearable by a lot of people, right?
And I don't know the details of that. I'm not an expert on that, but the principle is in play.
Yeah.
So that's what's happening. Yeah.
All right. Well, Dean, thank you for being a guest and sharing some of your thoughts here about bigger picture healthcare issues. I really appreciate it.
Okay. Thanks so much, Mark. Have a great rest of the day.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.